Our next speaker is Mr. Stephen Yeo. He is the Vice President of HIMSS Asia Pacific and Middle East, based in Singapore. HIMSS stands for Healthcare Information and Management Systems Society. May I request Stephen to please come forward.
As being said, I'm based out from Singapore, and I cover basically the HIMSS Asia Pacific and Middle East, and also the general manager for the HIMSS Analytics, which are looking in terms of assessing hospitals on their EMR adoption. So let me quickly spend a couple of minutes to really introduce HIMSS, as I know that HIMSS are pretty new in this region as well. We are a cost-based, not-for-profit organization, okay, which we focus on providing global leadership for the optimal use of information technology and management systems for the betterment of healthcare. And our mission are very clear. It's basically to really it's really looking at to lead the healthcare transformation through the effective use of healthcare information technology. So for HIMSS, we are 50 years old. We are founded in our headquarters in Chicago. We do have offices in the rest of the United States, and we also have office in Europe, in Brussels, Leipzig, as well as in Singapore, which is covering the Middle East and Asia Pacific. We have more than 38,000 individual members, and out of that, 2/3 of these 38,000 members are either clinicians, nurses, or healthcare IT professionals. We also have more than 540 corporate members, which covers the hardware, the software, the middleware, system integrators, consulting companies as well. And also more than 120 not-for-profit organizations, which is primarily the Ministry of Health, okay, in the different part of the world, and also hospitals, the healthcare providers. How we actually do the objectives, as I say, is really to transform healthcare through IT, and we work with the whole community, whether they are the users from the hospitals or the clinicians itself in the GP levels. We also look at governments, we look at vendors. And how actually HIMSS really drive these are into three pillars of our organization, which cover HIMSS, looking at community network building, providing education, and professional development. And then we also have HIMSS Analytics, which looking at the EMR adoption model, where we assess hospital, and we also do analytics in terms of where the healthcare market really goes. Last but not least, we also have the HIMSS Media, where we actually look into publication and industry news, which includes publication of books for the healthcare IT, including personal health, EMR, EHR, informatics for nursing and clinicians. We also have our healthcare IT news that we publicize as a newspaper. And also very important, we do have a digital copy of the Journal of Healthcare Information Management, which are widely being read by healthcare IT professionals. This brings me to today's topic. I'm talking about transformation of Indian healthcare using information technology. This was a topic given to me. But as I look at it, there are a lot of presentations for the last 1.5 days that touching on this. I'm not going to go through that, how India should be doing. But what I really like to do is to share with you what are the regional programs that India governments or the practitioner here can actually take a look and see how the healthcare industry here can adopt it. So if looking at the regional programs for Australia, recently they have announced a personally controlled electronic health record, which they also built as a PHR. That itself, okay, the programs will have a funding of $467 million US dollars. And the PHR system will be ready by the next year, July. And for China, they also have every year looking at a 5-year plan. Their key mission is really an urgent need to develop a healthcare IT industry that will catch up with the pace of health sector reforms, delivery model transformation, as well as the need to reduce the healthcare costs. This also in line that they understand the aging population. They also understand that, okay, there's a wide gap in terms of the wage, the wealth in the country, the rich and the poor divides. Similar in some way in India, but they are also focusing to make sure that the villagers, those that are below the poverty line, are able to access to care. So these include a multi-tier regional health network, which will tie in from the village, the county, the district, the city, the province, and all the way to the national level. And this itself will be a continual rolling fire plan as they move forward. For Hong Kong, they are developing an electronic health record sharing infrastructure. They are looking at connecting the Department of Health, the Hong Kong Hospital Authority, which comprises of 98% of the hospitals in Hong Kong. They also have the private hospitals, the clinics, the laboratory, X-ray, the clinician, nurses, and more importantly, they want to make sure that it gets connected to the patients. So this program had actually started beginning of this year, and it will take them another 2 to 3 years to actually complete that. For New Zealand, they actually just announced programs to achieve a high-quality healthcare and improve patient safety by the year 2014, so that all the patients will have a core set of personal health information that will be available electronically to themselves as well as their treatment providers. Last but not least, by looking at the other countries like Malaysia, like Philippines, they are also focusing on the primary care, telehealth, and telemedicine. And this project that they are looking on will continue to last for the next few years to come. What I really want to really share with you at this point in time is really take a look at when a country is building a healthcare network, they need to also focus on end-to-end delivery. And if possible, they also should look at a top-down approach. If taking Singapore as an example, they have very clear clusters. These are clusters of healthcare providers within the country. And Singapore are divided into 6 clusters. And each of the clusters will have the primary care, looking at screening and prevention, polyclinics and general practitioner, the clinics, the small clinics office. They also have the acute and intermediate care, which are comprises of the structured hospitals, the community hospitals, the rehab, as well as the support services. Last but not least, they also have to do connection with the long-term care, looking at nursing homes as well as a home care, and that is one of the key initiatives that are being driven. And this project has been driven since 2 years ago. And they are building different projects. 2 years ago, they started with $100 million US, phase 1 approach to build a national EHR infrastructure. This year, they are actually moving to a phase 2. Just with the national EHR itself, by connecting all the hospitals, all the clusters in Singapore, it will require for them to actually to make this to be a 10-year national plan to continue to evolve as they build on this. On top of that, they are building the community integrated care as well, basically to tie in all the community care, the step-down care, so that patients are able to move from acute care hospitals to a step-down care hospitals for intermediate care as if they are going to stay in the hospital for a longer period. Last but not least, they have just actually issued a tender on the personal health management. This will really bring in terms of connecting patients to GPs and then eventually to the national level. How this all can be done in Singapore is really that if you look at the future of Singapore healthcare IT, the patient is above all. They need to make sure that patients are the centric of the overall system that they are building. With that, they actually build the connectivity of every patient records. So even for the Singapore as an island country, there is broadband wireless available throughout the country. And now they are continue to build in more pipes so that anywhere, anytime in Singapore, you are able to get connected up wirelessly. The other initiative that they are building is really looking at one patient, one record. And then with that, they are able to look at how better clinical analytics for better health outcomes can be actually done through the information that they have collected, and then better patient relationship management through telecare that they are building. So as they build the personal health management, They are also looking at building a call center to make sure that when patients are being discharged from hospitals, they are being tapped on to remind them that they are taking their medicine. They are actually watching out their diet. They also need to make sure that they do their vital signs monitoring on a daily basis so that that will reduce the rate or percentage of readmission back into the hospitals. They also will be able to monitor their vital signs so that if they are diabetic, if their aggregated vital signs are above a threshold, they will be alerted to make sure that have you taken your medicine? Have you actually watched your diet? Or if not, you better come back to the hospitals and we need to make sure that proper analysis are being done on you. So this is the picture of the future of Singapore healthcare IT. From all these countries, what are the key observations that I actually derive in? Looking at that, telehealth and personal health is still in a very early stage. I think Dr. Ratta here mentioned that as well for India. So I think, again, it's no different for any other countries. Public health care is really, the governments will have to take a lead. As we look at in Asia Pacific, except Korea, most of the countries are driven by the governments because public health care is the main thing, and they own majority of the healthcare delivery. So the government will have to take a leading role, with a very clear strategy, with a very clear programs, and a very clear numbers in terms of funding the program. Not funding for 1 year, not funding for 2 years. It has to be a long-term commitments to make sure this happens. And how they're actually going to do that is a 3P concept. I think, Dr. Ratta, you mentioned that as well. We talk about public-private partnerships. So if we look at the models for Australia, New Zealand, for Singapore, each of them are different. Singapore is very much a hybrid. They build some, they buy some, they work with the private hospitals, private company to make sure that that strategy works. Looking at Hong Kong Hospital Authority, they have above 1,000 healthcare IT personnel, which is bigger than any IT companies. They build their own CIS, they build their own EMR, and many of the systems they build their own because they think that no one knows better than the whole system in the country than they themselves. So, and that is easy. They have 45 hospitals, which comprise of 98% of the healthcare providers in Hong Kong, and they have one system, they have one language, they have one policy. So very clear in terms of what they do. And then we look at research and application of telemedicine. Why is it still early stage? Some actually started with many years ago. But one of the key things that we look at is that there are some key factors that associate with that. One of it is really that there are no clear incentive why doctors have to change. There are also insufficient telecommunication infrastructure, especially in the remote side. I think as those have actually done telemedicine, you will know that the biggest challenge is really the last mile. So if you don't have that infrastructure in place, you are not going to get a very good user experience on that. There will also be a lack of qualified IT professionals to operate telemedicine system, a lack of a uniform health data standards that prevent efficient and accurate data exchange with any other telemedicine systems. So earlier on, how do we harmonize all the standards, whether it's DICOM, Knowledge, HL7, or IHE that are being used within the hospital enterprise? We need to actually look at how these standards are also harmonized for telemedicines. Last but not least, there is a lack of national telemedicine regulation limits to telemedicine development. Again, even though the private can drive their own, but because it's a public healthcare delivery, we still need to look at the security, we still need to look at privacy, we also need to look at regulations. What need to be regulated? I think that is important, especially when you move into personal health, you move into home care, and the law is always behind technology. And now iPad 2, iPhone, they can do many more, that regulators have become very worried. What is need to be regulated and what not to. So with that, what are the areas for consideration as we move forward? We really need to look at foundation of policies and strategies. Clear governance have to be set. Clear policies in terms of security, privacy have to be spelled out. I do see at some countries that are talking about EMR, electronic medical record, but at this end, for the law, they are still practicing to keep all the paper. If the paper are not signed, medical record are not signed and filed, they are still not legal. So the law have to change, okay, for that. The funding is to really get the program kickstart, get the program sustained and adopt, and then eventually they should be able to run on their own. And last, and also very important, to build the infrastructure. With that, we also need to look at the enabling policies and strategies. We need to look at citizens' protection, as I mentioned earlier on. We need to look at equality to make sure that all citizens get the same level of treatments. We need to look at multilingualisms. Like in Singapore, we have 4 official languages. Okay, even though English is our first language, but we have many older citizens that will require Mandarin, that will require Tamil, that will require Malay Bahasa. So all these systems and capabilities, we need to make sure that multilingualisms are in place. Interoperabilities, how to we ensure that whether we get interoperability at the system level, hospital level, or even at peripherals on measuring vital signs from patient. Last but not least, you have to be scaled, okay, capacity building. So with all this being put in place, very important, what is your business model? If you really want to bring from pilot proof of concept to become a real proliferation, you need to have a clear business model. That itself will have to cover the connectivity, the ease of use, the values to the patient, the values to the caregivers, the values to the providers. And these two really are the usage model. How do you develop your usage model to be clear? And then we talk about the cost model, the affordability. You have to be realistic. What is affordability? And then who pays? And you say that a party have to pay, then you say why they have to pay. So I think that itself will spell out your business model, and that itself will help you to grow. Technology is no more a problem today. Okay, if the business model is not clear, then the whole program is not going to take off. My last sharing is really on what is the next big thing. Okay, and again, pretty much we are very in line with Dr. Ratana's presentation, conversion of mobile health. I think that is what we see. Okay, as I move around the countries in Asia, everyone is actually start looking at mobile technology, mobile capabilities, and looking how it applies into the healthcare. And there will be a clear conversion as we continue to look at that. And that is why HIMSS also have launched our new society within the society called MHIMSS. Okay, and this itself will be a very new initiative, and it's an international global initiative where MHIMSS will look at the whole community. Okay, whether is it from the telecoms, okay, from patients, from the healthcare industry organization, clinical providers, policies, standard development, academia and research, finance, technology, as well as federal agencies, which I'm talking about regulators, okay, and policymakers. I think something that in future we can actually look at how we can collaborate on that area as well with India. So this is my last slide. Thank you very much. And if you do have any other questions that you want to get in depth with some of those programs that I mentioned, feel free to contact me or write to me. Or even then we do have an organization here called HIMSS, India chapter. So they have a booth out there, so you can talk to them as well. Thank you.
Thank you, Stephen, and exposing us to the telemedicine e-health status in the Asia-Pacific region. On behalf of the organizing committee, may I offer you a small token of appreciation for your time.